It's KUGN's Ask a Physician.
Ask a Physician is an educational program only. We do not give medical advice. The information we provide is not a substitute for professional care from your personal health care provider and is not to be used for diagnosing or treating a specific medical condition or disease. If you know you have or think you may have a health problem, you should consult your personal health care provider.
Now, Doc Talk on KUGN News Talk 590.
Good morning, everybody. It is 8:17. It is 60 degrees on this Tuesday morning, July the 31st. And it is a Doc Talk Tuesday. Look who's back in studio, Dr. John. Good morning, sir.
Am I making a rare appearance?
You are making a rare appearance. But, you know, it's always nice. We miss you when you're not here, and we are thrilled when you do walk through the door.
Well, you know, I have a lot of fun doing this. I'm very happy to be back. And today's show is actually really cool. So we're talking about the movement of healthcare reform and changes that are taking place in healthcare. And we've been talking about this for a long time. And certainly, if there are folks out there that have questions, concerns, please give us a call. We want to hear from you about your comments, concerns, questions about the changes that are taking place in healthcare reform, as it's called, and we've heard various other terms, Obamacare and all kinds of things. It's a change in how we're going to deliver healthcare, and we're going to talk a little bit about that today. The number to call if you have a question, 541-686-0590. And along with me today, I have a very special and interesting guest. Dr. John Sattenspiel is the Chief Medical Officer of Trillium, which is the coordinated care organization for Lane County. And we'll talk a little bit about this concept of coordinated care organizations as well as some other things that you're going to be hearing more and more about. In fact, we just talked about coordinated care organizations on the news.
We did. Oregon's ambitious experiment with redesigning the healthcare delivery system takes a big step forward. This week we are right on topic. Good morning and welcome, Dr. Sattenspiel.
Good morning. Thank you for having me.
Absolutely.
So, just to start out, we've been talking about changes in healthcare for a long time. And actually, probably most people remember a couple of decades ago during the Clinton administration, there was talk of this changing our health care in the United States. And since that time, we've heard about the Affordable Care Act and most recently the Supreme Court ruling that indeed that law is constitutional. Earlier this year, we heard about John Kitzhaber going to the Congress in Washington and asking for a health care waiver. And we'll talk a little bit about that. And so with all of this going on, what I think would be a good thing to talk about is just in general about healthcare. And Dr. Sattenspiel, I'll kind of start out with you. Why do we need to change? Why is it that it's felt that healthcare has to change?
Well, the bottom line with healthcare having to change is that this country currently spends more than any other country per capita, per person, per year on healthcare. And we can do better. We can become more efficient, more effective in the healthcare that we deliver. If you look at our overall healthcare statistics relative to the other industrialized nations in the world, this country does not show up very well. The whole idea of the coordinated care organizations is to try to become, as a community, more coordinated, more integrated, more collaborative in what we do so that we can reduce costs while still providing an equal or better level of service.
And, and what you're saying is absolutely my understanding. There's right now we spend approximately 17 or 18% of the gross national product in this country on healthcare. So about 20 cents out of every dollar goes towards healthcare, which is a huge amount of money. And if we do absolutely nothing, it's going to be about 25% or a quarter on every dollar by 2017. How do we know that this is unsustainable? Well, 60% of bankruptcies filed in this country are because of medical debt. It's a huge problem, and just like Dr. Sattenspiel said, we've got the biggest economy in the world. We spend the largest proportion of that economy on health care, and we didn't even talk about the quality issues.
Well, quality is an issue. We at Trillium believe, though, that the primary issue with quality is not that our doctors and other providers don't know how to deliver it. It's that the system is not designed in ways that really help them. Our emphasis as a health plan is to try to figure out how we can help our doctors and other providers in the community do their jobs better.
And, absolutely, it seems as though it's not the people. The people within the system really want to do a good job. It's the system that we use is broken. And we like to think in the United States that we have the best of everything, including the best health care. And there are some things that we do extremely well in the United States that other countries don't. But, if you look at one statistic, which is life expectancy, well, we're at number 50. So there are countries where people presumably are healthier and they're living longer and they're spending a lot less on health care than we are here in the United States.
So what are we doing wrong?
What are we doing wrong?
Well, that's a very good question. I don't know that anybody has a clear answer to it. Now, I will speak for myself as a primary care physician. I spent 24 years of practice in Salem, Oregon as a family doctor. And our belief, of course, in the primary care world is that we have moved away from the concept of primary care as the heart and soul, the primary place where people should get their medical care. That's not to say that specialty care is unimportant, but having that connection with a doctor who knows you as a person, who in many cases has cared for you from birth to death, makes a difference. Most of the other countries, virtually all of the other countries that have better health outcomes than the United States, have health care systems that have far more robust primary care than what we see in the United States.
This concept of primary care physician, I think it really came from the managed care era, which to a lot of people, that has this bad connotation to it, managed care. But the concept that occurred back in the 80s or so was that you had this primary care physician that would help direct your care. So you had, they called it a gatekeeper. Well, that's really not it. It's sort of your primary contact with the healthcare system. And, those also happen to be the first time in a long time that we actually saw healthcare expenditures go down for a very brief period of time. And for various reasons, that managed care era kind of came to a close. A real important concept here is this whole idea of access, people's access to healthcare. And at least in this country, and at least with our current system, that key of getting into or access to the healthcare system is insurance. Why? Any comments about that, Dr. Satt, about health insurance and why it's so important and the access problems and how that leads to some of the dysfunction we see in healthcare today?
Certainly. The big issue with insurance is simply that it is the mechanism by which in this country we have chosen to pay for health care and allow access. So if you don't have insurance, you don't completely lack access to health care. But the only access that you really have available to you is through emergency rooms when you have an acute problem. And when it comes to managing health and helping people to be as healthy as possible, to live the best quality lives as possible, it's not about getting care when you have an emergency. It's about getting the care that you need that will help you to stay healthy. It's about taking care of your diabetes on a chronic basis. It's about taking care of your high blood pressure. It's about getting your well child checks and your immunizations.
Yeah, and the emergency room particularly the emergency room, and this is something that I certainly see as a primary care physician here in Lane County, and there are lots of areas around the country, inner cities, busy cities, where you see pictures of an emergency room, and it's a lot of people that have fairly straightforward problems, not emergencies, and this is the emergency room is the most expensive venue to receive, antibiotics for a sore throat or medication for a cough, as opposed to a primary care physician, because of course the emergency room is staffed. It's part of a hospital. It is designed to deal with major traumas, with heart attacks, and so you add all that expense to a relatively minor problem, and you start seeing things like, well, it's a $600 sore throat, as opposed to in a primary care office where their expenses are designed to manage those sorts of simple problems.
So folks are going to the emergency room because they don't have insurance? Is that what you're saying?
Well, I mean, there's a lot of reasons why people go to the emergency room. One is that they have an emergency.
Sure.
Two is that they feel that their health has gone significantly in decline, that they've initiated EMS, and an ambulance brings them to the hospital. Some of those patients just have nowhere else to go.
Sure.
I feel bad. My back hurts. I have a fever. Some of them, I have chest pain, and they're not having a heart attack, but they think that they are. Mm-hmm. They have a symptom that they're concerned about. They go to the emergency room. And a lot of times it's people that have no other place to go. They don't have a primary care physician office to call.
All right. We're in the middle of a Doc Talk Tuesday. We've got Dr. John Letovsky in studio, along with Chief Medical Officer for Trillium Health Plan, Dr. John Sattenspiel. 541-686-0590. Our topic this morning is healthcare reform, coordinated care organizations, folks. If you've got any questions, concerns, or just comments, now's the time to call 541-686-0590. We are KUGN News Talk 590. We'll be right back.
Snotty noses, headaches, shin splints, and tumors. Just a few of the things you could bring up with KUGN's Dr. John. Ask your medical questions every Tuesday morning at 8. It's Doc Talk with Dr. John Letovsky, only on KUGN. It's Doc Talk on KUGN News Talk 590.
Indeed it is. It's a Doc Talk Tuesday. Dr. John Letovsky in studio with us also. He's brought along a special guest this morning in Chief Medical Officer for Trillium Health Plan, Dr. John Sattenspiel. And we are talking about health care reform, coordinated care organizations.
And if you have any questions or comments about health care changes that are taking place, about the Oregon Health Plan, about coordinated care organizations, the number to call is 541-686-0590.
So we had a story in the news, which has been in the news days now. Oregon's ambitious experiment with redesigning healthcare delivery system takes a big step forward this week. New coordinated care organizations will launch tomorrow with 260,000 patients. Can you talk about what that means, launching tomorrow?
Well, certainly the bill that enabled the coordinated care organizations was House Bill 3650, and it set the start date for those organizations of August 1st. That's a very short timeline. It has not given any of the organizations in the state a lot of opportunity to really develop comprehensive plans, and yet we are required as of that date to start functioning as a CCO. The intent, I'm certain, was to ensure that the stakeholders in a community must come together to cooperate, to collaborate, to develop a plan that, in fact, can be applied to the Oregon Health Plan members in their community and will be effective in doing the things that CCOs are supposed to do. Specifically, coordinated care organizations are intended to ensure that all of the parts of the healthcare system begin to function well together. We need to learn how to communicate with each other. We need to learn how to share information so that all of the things that impact a member's health can be addressed. In particular, there's a lot of data out there that says factors such as what's your housing like? Do you have access to adequate transportation or high-quality nutrition? Issues of health literacy, things that actually are out in the community but not necessarily addressable in the doctor's office, those things will have a tremendous impact on how healthy someone can be. In a coordinated care organization, for example, here in Lane County, we have brought together the physical health organization, the mental health organization, that would be Lane Care, the county public health organization, senior and disabled services, and multiple other advocacy groups, provider groups, and other stakeholders in this community to all get together in one room and talk about how can we all work together to do this better. So,
coordinated teamwork.
Mm-hmm, sure.
I've kind of thought about I've thought about this a little bit and liken it to imagine that you're going to remodel a room in your house, right, and you're not quite sure how to do it, and you say, well, I think I need a framer. I probably need somebody to hang drywall. What you didn't realize is, well, there's pipes in the wall. You need a plumber. And instead you take out the wall and you've got a mess to clean up.
Right.
Or didn't realize that there's some wiring in that wall. This is sort of like, well, you get everybody in a room and they say, oh yeah, plumber's right here. Yeah, we need you. The electrician may say, all you need to do is just you're going to move that outlet. You really don't need me. But you do need, this guy. And so it's getting everybody together on the beginning of a project rather than, as a primary care physician, I will see someone in the office and I'm not really, I know what to do on my end. I know what medications to prescribe. I think I may know some therapy that they might benefit from, but I really don't know that there's all of these other issues that is going to impact this person's ability to achieve optimal health care.
541-686-0590 to call with your questions. Let's welcome in Cooper. Good morning, Cooper.
Good morning. So I heard Dr. Letovsky mention being a primary care physician. So my question is he moved back into that area, or is he still being, as you might say, a sub at different clinics? He used to be mine, and I'm still looking for one.
Oh, I'm so sorry. Yeah, at this point in time, I'm still rotating around, filling in at different offices. I haven't gotten back to starting a panel of patients. But thanks for I would love to get back into it.
Okay, well, I sure would like you to also.
Well, thank you.
Very nice, Coop. All right.
I owe you a quarter.
All right.
Thanks for checking in. All right, 541-686-0590. The phone lines are open if you have any comments, questions, or even concerns. Healthcare reform, coordinated care organizations, that's what we're talking about this morning. So,
I want to clarify that when we're talking about the coordinated care organization, we're talking about Oregon Medicaid, we're talking about OHP. And just to take a step back in, we've had the Oregon Health Plan since about 1993. Back then, that really put Oregon on the map in terms of healthcare reform and thinking about healthcare differently. What was different about the Oregon Health Plan back then compared to other Medicaid programs?
Well, there were really two primary differences between the Oregon Health Plan when it first came out and other health plans in the country. The biggest difference was that the Oregon Health Plan is based on the prioritized list of health services, and that was an effort that involved all of the healthcare stakeholders in the state. That's providers, hospitals, professional organizations, consumer advocacy organizations, but they all got together with one charge, and that is figure out which are the most important healthcare services to deliver to a population, put them on a list in order of importance, and then we will determine which ones we will pay for based upon how much money we have, rather than the old method, which was if you had a Medicaid health plan, you got pretty much everything, and if you ran out of money, today you got everything, tomorrow you get nothing. The way the Oregon Health Plan was designed was that today you get this much off the list. If we're running short of money, tomorrow you're going to get just a little bit less off the list, but we're really going to continue to give you all the important stuff. The other thing that the Oregon Health Plan did that was different early on was because of the way that was structured and funded, our Medicaid dollars were able to go farther in terms of how many people were able to receive health care benefits than in other parts of the country.
And obviously there were some challenges with the Oregon Health Plan back then. Why change to the coordinated care organization?
Well, what has happened is that health care costs have continued to inflate at a rate that is faster than the general inflation. It's become more and more difficult for the state to finance even the basic levels on the prioritization list. And it's become clearer and clearer that we can do a more efficient job of using those dollars if we can learn how to better communicate, collaborate, and coordinate the care among all of the necessary services that are being provided to a particular member in a community.
541-686-0590, again with your questions. Let's now bring in Nick. Good morning, Nick.
Well, hey, good morning, gentlemen. First of all, I enjoy your show very much. Thank you. Real quick question, twofold question is, one, with Obamacare, what will the financing aspect be as far as funding for all the additional people that will be going into the programs, as you described, the basic coordinated care systems? But more importantly, how will that affect the access that the individual right now may have? I do see my physicians quite often, and I am concerned that with Obamacare and the amount of access of everyone now being able to see a physician, be it a primary care, hopefully a primary care physician, how will that be impacted by the volume of patients coming into the system, and how will these organizations that you're describing be able to respond to that?
Nick, thanks for the call.
Yeah, those are great questions.
Yeah. And I'll take the answer off the air. Thank you.
Thank you so much.
Thank you, Nick. That was indeed an excellent question. Access is going to be an issue. We know that in this country we have not trained enough primary care doctors, so it is going to be a bit of work on the part of all of us to be able to make sure that everybody is able to get in to see a physician, a nurse practitioner, a PA as needed to make sure that their health is really kept at its best possible state. As far as the impact of Obamacare, the federal government will be financing a Medicaid expansion program beginning in 2014. They will be paying 100% of the financing of the extra cost for expansion of that Medicaid program for the first 3 years, subsequent to which, following which, they will then be paying 90% of the costs. So from the perspective of the state, this is something that really does not impact the state budget and is something that we are very much looking forward to, because it will move us closer to ensuring that all of the citizens in Lane County have access to good quality health care.
And, of course, paying for the Affordable Care Act in general, the financing comes from a few fees that come from insurance plans. There are tax dollars, and I think, it's estimated that it's going to cost $940 billion over 10 years. But there's another piece that we're also anticipating we're going to benefit from, which is some cost savings, keeping in mind, of course, that places like government, state, local, federal, all of their employees are getting health care. And if we can hold down the cost, the government will actually be saving money as well. So it's a very complicated issue. But that was, great. And, the one thing about how are we going to absorb all these extra patients when in 2014 there's 35 million more Americans that are going to have health insurance and need a primary care physician. And a lot of that is going to stem on the ability to come up with novel models of care that are going to use physicians as well as nurses, so that a team approach is able to take care of more patients and higher quality. So, and that kind of gets back to this coordinated or teamwork approach.
One of the questions here says, for someone currently receiving Oregon Medicaid, what will they notice is different come August the 1st, tomorrow? Are there differences that they're going to notice?
They will, in fact. They will have a different logo or a different name on their Medicaid card. That's pretty much it.
Wow, all right.
Coverage is not changing. The physicians who will be delivering the care are not changing. The hospitals are not changing. Nothing is changing except the name on the card. Now, underneath the surface, there is tremendous ferment, and there will be tremendous change as we as a community become more efficient and effective in our ability to meet the needs of those members. They may find, for example, that if they're having difficulty remembering to take their medications, they may find that a community health worker will come to visit them, to work with them to identify little tips, little tricks that they can do, things around the house. Where do they put their little Post-it so it will be most effective to remind them to take their medications on time? So we will have other things that will begin to happen, but those are going to have to be developed going down the line.
Okay, I was just going to ask what are some of the other things, because, I mean, that's wonderful to point out something like that. It's just like, wow, what a great idea. So other maybe things in the works that you can share with us?
Well, at this point, I think the biggest thing in the work is the communication and collaboration piece. Trillium has been working within the community for literally the last 2 years to develop the relationships that are coming together to form the CCO. We know that we are going to be doing some specific targeted quality improvement projects. We will identify them, though, not from the perspective of what to the health plan looks like the best thing to do. We will identify them from the perspective of the community. What, as a community, do we think we need to do? We will be looking at alternative allocations of money. We've seen a proposal. It's not one that is in active discussion right now, because right now the CCO is trying to form itself. But we've seen, for example, a proposal that says if you have somebody who is homeless who ends up in the hospital, by providing them 30 days of housing, you can reduce costs going forward by thousands of dollars per year. So we will look at a proposal like that, because spending that money on housing, spending $1,000 on housing for a month or whatever that cost may be to save $10,000 in health care costs is something we ought to consider doing. We can't consider it right now because the dollars come from different places. If I take my money to pay for your housing, the money that's coming back is going to go to somebody else, and that's not a good situation from the perspective of those various organizations. Under the CCO, we're all in the same room. The funding belongs to all of us, and the benefits accrue to all of us.
You know, it's a lot of the social factors that play into someone's health are it's very real, and for a long time it's something that was very frustrating to a physician, because I could very easily see that the reason somebody's diabetes, or at least one of the reasons that their diabetes is under such poor control, is one, they have suboptimal housing. Maybe they are living in their car, unfortunately, and we've got a lot of folks that are doing that. Or they can't afford a diabetic prudent diet, and therefore their diabetes is out of control. And I see them in the office multiple times following up emergency room visits for diabetic ketoacidosis, which is a life-threatening complication of diabetes out of control. And I have very little to do. I throw up my hands. I try to do the best I can, but I realize it's more than just taking the insulin. Sure. There's a whole bunch of stuff that we're ignoring, and this approach with the coordinated care organization will take that into account and have some fixes available, right?
That is correct.
So there's a lot to do. How soon do you see things starting to really smooth out and start working functionally?
That's a very good question. My crystal ball, unfortunately, is a little bit cloudy right now. We have, from the state, some very tight timelines. We have to submit a draft plan for how the CCO as an organization is going to transform healthcare delivery in Lane County. That has to be submitted by the 15th of September in draft form. In final form, it is required to be submitted 90 days after that. We are on incredibly tight timelines to do something. So right now, what we're focused on is the design piece. First of all, we got to figure out what is it that we want to try to do to transform healthcare. And then going forward, we will begin the actual application steps where we do the things that we are going to be promising the state and the community of Lane County that we will be accomplishing.
Very good.
So it's kind of like, some summer practice. You're playing. Chip Kelly has his team out there.
Right.
They have their goals. They got their playbook set up. They're right. They got a few little things that they got to do just before the opening game.
Right.
Yeah.
Right.
So it's all the pieces are there, and we know what we want to do. It's just getting it all to work out.
Sounds excellent.
Yeah.
It's exciting times actually. Dr. John Letovsky in for Doc Talk Tuesday. We've got a special guest in Chief Medical Officer Dr. John Sattenspiel. And it is 8:52. We're going to take a short break. We still have time for a call or two, 541-686-0590. We'll be back after one more break here on a Doc Talk Tuesday. KUGN News Talk 590.
It's Doc Talk on KUGN News Talk 590.
All right, folks, just a couple of minutes left. 541-686-0590. If you have a question for either Dr. John or Dr. John. I've been wanting to say that all morning.
And we had a caller with actually a very good question, and that was, how does this affect Medicare? And the answer is it doesn't. The Coordinated Care Organization is about the Medicaid or the Oregon Health Plan folks that are been getting Oregon Health Plan all along. Now, Medicare does have a different program that is set in place and funded through the Affordable Care Act, which is the Accountable Care Organization. And there's some similarities, but the bottom line is it's getting better care for less money by using resources more wisely. And that's another program. I wanted to get back about the Oregon's Coordinated Care Organization and the use of community health nurses and how a patient on the Oregon Health Plan is going to notice that there's this extra resource that they have. How does the community health nurse come into the picture?
Well, The program is just under development. The first group of community health workers has completed their training at Lane Community College. And once we have them well established, well trained, and ready to do their work, the referrals to community health workers can come from the primary care medical home. They can come from discharge planners at the hospital. They can come from social service agencies such as Senior and Disabled Services. They can come from the mental health organization, Lane Care, and the services they provide. Anyone who touches the health care of a member, anybody who participates in that health care process, has the ability to connect with community health workers when a need is identified.
And I think we've got about a minute and a half. Yeah. Very quick, a couple quick questions. One is the behavioral and mental health component of the coordinated care organization. And also this concept of moving a little more towards preventative and being proactive rather than reacting, waiting for somebody to get sick and taking care of them, instead recognizing we can do these things to keep them well. Your thoughts on those?
Well, those are obviously key components of what the CCO is trying to deliver. The integration of behavioral health with physical health is absolutely critical. We know that there is a huge burden of physical ill health in those who have mental illness. Their life expectancies are lower, their disease rates are higher, their ability to care for their conditions is impaired in many cases. So we know that addressing those issues and coordinating what the various pieces of the system are doing is going to be very important. As far as being proactive, absolutely. This is about trying to identify issues that can become problems and then doing something about them before they become very expensive to deal with.
Very good, Dr. John.
Yeah, it's a lot less expensive to prevent a heart attack than to pay for one after it's occurred.
Doc Talk Tuesday, fabulous having you in here this morning.
Thank you, and thank you so much, Dr. Sattenspiel. Very exciting project you've got underway, and a grateful community that's going to benefit from it.
Thanks very much.
The Mike Huckabee Show is next for Storm Kennedy. I'm Grant McHill. Have a great Tuesday. Talk to you tomorrow morning at 5:30 on KUGN.